Thank you, Kevin. I first want to just say I'm speaking as an advocate. I am employed by the University of Kentucky, but the things I'm going to tell you are my own thoughts. Kevin asked me to talk about the term second victim. We had this editorial, so I'm going to give you the journey that I went on during the past 7 years to get to the point where I was writing this editorial. So I'm going to begin back in 2012. My family's experience with medical harm back in 2012, just over 7 years ago. So in brief, my father was burned very badly in Kansas. He was taken by my mother to a local hospital, but that local hospital delayed his transfer to a burn center for about 15 hours. He did finally get a transfer. He was in really bad shape by that point. He had skin graft surgery over his entire back, but it was just downhill from there, and we terminated life support about 7 days later, and he died. This happened while I was a PhD student at the University of Washington studying biomedical informatics. And I had a class in clinical informatics, and we had talked about medical errors from kind of a systems perspective. And so I knew that things should be happening in that organization. And I should clarify that when my father arrived at the burn center, they immediately told us he should have been transferred earlier. So we knew that there was a delay and that should not have happened. So my concern was, did the local hospital know the delay had happened? And so now I was in a state of both grief and confusion. One thing I did was I was like, well, when you have a question, you ask Google. And so one of the things I Googled was the term victim of medical error, because I thought, well, maybe this will help me find a way forward. And well, if you do that today, you'll find results similar to what I found 7 years ago. What was coming up were this term second victim. I was confused. I mean, I was not stupid, so I eventually figured this out, but this was not at all the information I was looking for. I was looking for support. I was looking for who do you turn to when you know some type of error happened, but you don't know the full information. This was not helpful to me. It was confusing. But Google has its own point of view. And so in looking at the results that come back today, I made you this visualization. So if you type in, at least in the settings I have on my Google search engine, victim of medical error, these are the top 50 rankings that will come back. So I've got them over on the left-hand side. I've got type of information. So there's two different audiences, patient family and then healthcare professionals. And so the ranking of the search results that I got back earlier today, number 1 is at the left side, and then 2, 3, 4, 5 up through number 50. So each one of these little rectangles represents a search result. And the ones down there on the bottom row in red, those are the ones about second victim. Now the ones that are in open boxes, those were prompted by my article, so you can kind of ignore those as being a valid just sense of what does the world say out there about second victim, about this term victim of medical error. And this is really revealing when patients, I don't think I'm the only family member or patient to type this in. We ask Google questions all the time and look at what is coming back. It's not the things oriented to patient family, it's this second victim. And Google also it suggests related searches. And here's the related searches for victim of medical error. All of them are about second victim. As Kevin mentioned, Albert Wu introduced this term second victim in an editorial in the BMJ in 2000, and he was making a good point. He was saying that physicians who were involved in a medical error, some type of adverse event, it can be a really stressful, psychologically difficult, sometimes even traumatic experience, and that it's crucial to recognize that and support healthcare professionals that are involved in these errors, these events. And I completely agree with that. What he also did was he introduced this term second victim. And that term has, well, it's taken on a life of its own. After my father died, I became an advocate for safety and transparency and patient rights. And so I started a blog, and I was getting involved in the community, and I was meeting people, and I kept hearing this term second victim. So the 3 times that stand out in my mind the most, here's these 3. So the first one, patient safety training program for resident physicians. And my family was invited as a patient family representative, and the trainees were medical residents, and they were having a week of intensive training in patient safety. And it was during a breakout session that one of the residents mentioned to me the term second victim. And I had formed an opinion that I didn't really like that term. And through some conversations with other patient advocates, I was getting a sense they didn't either. So I spoke up. I don't remember my exact words, but I pointed out that term has some problems and patients and families don't really like it. But this was a very, very enthusiastic resident, and she really liked the term, and she said, well, maybe you could be the third victim. And she was super excited about this idea. And I was just slightly horrified. And she also said, well, we'll never use it around patients and families, so it's okay. And I'm like, oh. So I felt uncomfortable about that experience, but okay, go on. Somewhat later, patient safety meeting in Kansas. It was risk managers and other hospital representatives from the state gathering together for a day of speakers and seminars. And one of the speakers, during a keynote presentation, mentioned the term second victim once. Now, at the end of the presentation, there was time for one question, and the one question that was asked was, what do we do to keep from being victimized by all of these medical errors? As an asked from the viewpoint of the healthcare professional. And I was just horrified. That's what that woman got out of this 40-minute talk. And then my third very memorable experience happened here with a patient safety organization in Kentucky. This was not Health Watch, it was another one. And when the term second victim was mentioned, I tried to do a very low-key response that term is kind of problematic with patients and families. And that prompted a very, very passionate rebuke of that position and defense of that term. And after that experience, I decided that, okay, I need to do something about this. This term isn't helping, but people seem to not know that there's a problem with it. And by this time, I was pretty darn aware that many patient family advocates are uncomfortable with this term. But one problem identified is there's no evidence of this discomfort in the medical literature, because the medical literature is from people inside the healthcare system. And why would they take up this issue even if they don't like it? It's probably not that big of a deal to them. So when papers are written, there's very little dissent in using this term. And so I decided that there needs to be something in the literature. And so I started looking into this, and I discovered it's not just second victim, but now second victim syndrome. Okay. And then I got a surprise. There's now second and third victims. And I'm like, oh my God, this term is expanding and mutating because we in academia write stuff, I guess. Okay, so in this context, the third victim is the healthcare system and/or its reputation. Well, it doesn't stop there. Other authors even have defined fourth and fifth victims, and depending what you read online, it could be healthcare organizations, the healthcare organization's reputation, support staff, the healthcare system, other patients, society, and this is going to an extreme that is just not helpful to anybody. Okay, so again, my goal was to get a patient family viewpoint opposing the term second victim into the literature. And I wanted to make sure it wasn't just me. I needed a sense of the patient advocacy community. So I reached out to the most prominent patient advocates I know, and we started a conversation about what this would be, and they were totally on board with it because they were very uncomfortable with this term too. So I sat down to draft something out last winter break when I was visiting my mom, and I thought, well, what is something that might resonate with people? And so I centered my argument on that the victim mindset is incompatible with patient safety. And so the way I explain this is that, well, victims, they have no responsibility. There's no accountability for addressing problems. They're passive, they lack agency. And by using this term second victim, it obscures this idea that healthcare providers can become unintentional agents of harm. And that realization, keeping that in mind, is crucial for patient safety. So that's where I came up with this conflict between this victim mindset and patient safety and just being incompatible. This ended up as our 800-word editorial in the BMJ. So the reason I was super happy that the BMJ accepted this. So this is the venue that Albert Wu used to introduce the term. And so I thought it was very appropriate that this is where we first submitted to get our article into the literature, and they accepted it. Now, one small side note is the subheading, avoiding responsibility, that was added by their editors during the copy editing. I actually did not write that. And when I got the proofs back, I didn't think much of it. But now, in some of the responses to the article, they really jumped on us about that. What I was trying to do was carefully and subtly build my argument up to the avoiding responsibility part, but they put it there very bluntly. I'm like, well, then again, that's what our argument is leading to. So, well, that is, they switched to British English, so I didn't write in the British English, their editors did. So. And there it was. And this came out in mid to late March. And, well, Helen Haskell tweeted it, and it got retweeted a lot, and we got a lot of Twitter activity on this. There's over a dozen responses online on the BMJ site, and a number of them are very supportive, and then we definitely have some lengthy ones that are disagreeing with us. So some of the common objections to our article, I've got a few of those for you. One is this. They say, you didn't suggest another term, so we have to still use the term second victim. First of all, I don't think we need a term. We can just say physicians, nurses, healthcare providers involved in a harm event. I don't think we need a certain term for that. Although I will say, from an academic literature standpoint, yes, it's great to have that unique identifier. I can just suddenly pull out a bunch of literature. But in the real world, we do not need that term. And it is not practical to think this term is ever going to be replaced. It is just not going to happen because this term is sticky. There's a book published several years ago called Made to Stick. And these authors, they have 6 criteria for what makes ideas sticky, and this term fits 5 of the 6. It's simple, unexpected, credible, emotional, and it inspires stories. So there is no chance of this term ever being replaced with another term. I think that argument is just leading down a path nowhere, and we need to work to just remove the term, not replace it. So another objection is that we just don't understand what it's like to be a physician or nurse, and we don't understand that they are victims too. And I wish I could have elaborated a little more in the editorial, but we had a limit of words. I do say in there that we support care for the caregiver programs. So I want to make it very clear that we realize involvement in a harm event can be traumatizing, and I expect institutions to support their healthcare staff because I want the people taking care of me to have good mental health. And that means having care for the caregiver programs. So it's not that I'm arguing that doctors and nurses involved in harm events aren't disturbed by it or they don't need help. I just think the term victim is inappropriate. This is my last slide. I just kind of want to open this up to some discussion. And so do providers really consider themselves to be victims of medical errors, or is it victims of something else? In the responses to our articles, several people were writing in to give stories about how badly institutions treat physicians and nurses involved in harm events. And so that's a bit of a different thing. Do the people who like this term, do they really see themselves as victims of errors and harm events, or are they victims of how their institution treats them after harm events? And this is an important distinction because things like training on second victims, there's lots and lots of educational and training programs. If those are training programs for second victims, that doesn't make so much sense if this victimhood is coming from the institution. Instead of training people in this mindset of victimhood, the effort should be towards changing institutional culture. And my second point here is I've never seen a good argument for why a mindset of victimhood is valuable. I've read all of the responses to my article, and no one is telling me directly addressing this issue. Why is this mindset of victimhood valuable? And finally, the other point that comes up is all of this attention is going on providers. Well, what about the patients themselves? There is very, very little about the impact on patients themselves. There is one master's thesis I found from many years ago that talks about symptoms similar to PTSD in patients, but this is not peer reviewed. This was just a student's master's thesis. And that's really most of what I can find on the psychological impacts on patients. But yet we have all of this about what happens to the providers. And I think this getting into this term second victim has really shined a light on this imbalance that healthcare institutions want to claim to be patient-centered, but when we look at what's actually written about, what people actually talking about, what's the training actually about, it comes back to being provider-centered. So that's what I have for you, and I would love to hear your thoughts and comments on this.